I think we will have to see. You know, the results of the recovery trial, the preliminary results, you know, are quite remarkable. That this could be this is a life-saving intervention in severe and critical illness. What you're asking is whether or not that will reduce the need, you know, reduce progression of disease, and that will reduce the general estimates of need of oxygen. So we'll have to see. I think, you know, we're working with many different experts on how to best model this, how to best forecast the oxygen need, you know, and also understand the capacity at country level, you know, in order to make that gap assessment more accurate. So this is ongoing work, and I think as we will continue to refine our tools, and also take into account potential treatments that may impact that estimate.
If I could just add on this, because we tend, you know, we get positive information on remdesivir, and then we all chase that for a while, and then we get stuff on dexamethasone, and then we have a discussion about oxygen, and then we have a discussion about other things. I think we need to really start seeing this as how do we optimize the clinical management of all patients who become sick. From the very moment that someone feels sick, getting an early diagnosis, being able to see a qualified physician or nurse, and understanding that physician or nurse, being able to understand your underlying conditions, your likely risk, and being able to put you into a pathway to see and seek and have the right care available. Because it's not just about having oxygen in a country or having a drug in a country. It's about making sure that the right patient gets access to that intervention at the appropriate time during the course of their illness. And when you put all of those small interventions together, rapid diagnosis, early hospitalization of those patients who may have risk factors, early oxygen therapy when needed, and then the use of other drugs and other supportive care, including ventilation, dexamethasone. And if we're capable of putting all of those interventions together and ensuring, even in least developed situations, even in humanitarian situations, we can deliver a basic standard of care to every person who gets COVID-19, then we will save a lot of lives. When we look at dexamethasone and we look, it reduces death rates by 1/5 in people who are already on oxygen. That's great, but by itself, it's not a solution. If we look at remdesivir, it reduces the length of illness in a proportion of patients. That's great, but it's not enough. But if we put different therapies together, different interventions together, and we deliver them in a fair and equitable way, then I believe we can do much more. So I think we need to look at, and again, Dr. Tedros has challenged us on this over the last number of days. How can we put together all that we have learned to reduce mortality? And reduction in mortality starts at protecting those people most at risk, shielding people, first and foremost, from the infection, so they never get it. And that's how you reduce mortality. And you start there and you work your way forward. And we need a really comprehensive look at what is affecting mortality. And what's affecting mortality is not always just the fact that a drug exists or an intervention exists. There's no point knowing that oxygen works if you're in a refugee camp in Somalia and you have no access to oxygen. That's no good. Knowledge is no good without the actual resource available to the doctor or nurse. So we have to turn knowledge into know-how and know-how into how-to. And we need to turn the how-to into the materials and the resources that are needed in order to affect the mortality outcomes in this disease. So I think it's really important, and Janet and her team are really looking at how we can put that system of, you were saying yesterday, Janet, the structures, the supplies, the system, the security, and all of the elements of an effective clinical management system. And we've learned so much about how to do that better. We just need to apply it now in a much more systematic way, especially for those people who live in fragile, conflict-affected, vulnerable settings who may not have access to healthcare like others around the world may do.
Many thanks. And for our last question for tonight, we will stay in the United States. We have Jim